Very good evening. So here we are to discuss about the obstetrics recall NEET-PG 2024. So I would like take this an opportunity to appreciate all the students have taken a lot of hard work and even with lot of hurdles that was coming all this time, and there was a lot of postponements. With all that, your determination and persistence have helped you to finish your exams. So results comes the secondary. Okay. So how was the exams? Next week we talk about how was the exams. It's very easy for me to tell the questions were easy because I see these cases in and out. Is it not? For you people, mastering all the 19 subjects is difficult. But one thing that I could tell you is one important they expect you to know is the basics. That is, any topic you read, they want you to know the basic concepts. That is the main essence for any success. If you have to see any subject, it's not only for my subject, I'm talking about any subject, you should have to know the basics or the concepts. Your basics or concepts is fine. It's a very firm and you have a strong foundation on particular topic. Then even if they twist or they ask you in a different way, you'll be able to answer. So that is what they're trying to do. Okay. Most of our questions were like that. And one good thing that I could observe from these questions is there's not a lot of surprises. There's no surprises actually. In the sense they were not asking any recent advances or newer things. They were asking questions from the same topics in a different way. That's all. So if you could have applied your concept, I think most of you could have answered these questions. I'm not discussing as a morning session, evening session, because this creates a lot of things that the morning session was easier, afternoon session was difficult. All that is secondary. Here we are to discuss to see where we have gone wrong, where we could make it right. This is for the next coming batch also. Where to concentrate, where not to spend a lot of time, where what can the things that make you more stronger. Okay, so that's why we have a recall. Nothing to point out this was right, wrong. Okay? Just to know where you've gone wrong, where you could have made it right. Okay. So coming to the first question, what is the mode of delivery in a multiple twin gestation? They've given two images. We had a simple concept, is it not? It was a discussed topic. So it was a very simple concept that if the first twin is a non-cephalic, rather than a vertex presentation, you take the patient for a cesarean section. That is a hard and fast rule that we have read. So this is how we have discussed, is it not? So we discussed the periodicity. At what period of gestation? That was a one anticipated question. What period of gestation we deliver the patient? Another one is at what time is the mode of delivery? What is the mode of delivery? Always remember the first twin, if it's a cephalic, only you go for a vaginal delivery, provided the second twin, it is a whatever lie it is it not? And the first twin, other than a non-cephalic or non-vertex presentation, if it's a breech or transverse or oblique lie, we go for a cesarean section. That was a simple approach. In an MTP, medical board are all except. So yes, MTP again was a very anticipated question. Yes, they have asked one which everybody would have answered. This was a little, I won't say tricky question, but this was also an answerable question. Okay. Who are the medical board members? So they obviously there is a radiologist, there is a pediatrician, gynecologist. C and D, everybody will have known they are the members. Radiologist and advocate would have been a little this one. Yes, radiologist is a member. An advocate is not a member, provided, remember, there's another member for that particular anomaly. For example, if a cardiac anomaly is there, cardiologist will be giving an opinion. So similar, that is how the fourth member keeps on changing depending on the anomalies. That is what the medical board members are. Okay. This was again a simple approach. Yes, amendments. We were seeing what are the amendments we were seeing. Please remember, one important thing that they do is this: 24 weeks is for the rape survivors. Beyond 24 weeks, even if it is a fetal abnormality, can be terminated even after 24 weeks, provided if they have to get approval from the medical board. That is what is a new amendment. There's no limit that 24 weeks is a limit beyond which you cannot terminate the fetal abnormality. It's not like that. You have to prove in front of the medical board this baby after delivering it's not going to survive. There's no point in continuing the pregnancy till term and delivering. So those kind of patients who, for example, they are diagnosed at 25 weeks, is it not? There's still a long way to go. They can apply in the medical board and they will give accordingly, see the what kind of anomaly, if there is a chance of any surgical intervention. Based on that, the approval is given. Yes. Oncology, I expected a lot of questions. I think all of you would have put a lot of effort to read oncology, is it not? So everybody have that in a base that oncology is the difficult part. So everybody would have stressed a lot on this oncology part. So they've asked on a simple clinical, the staging, and even the staging, they've straightforwardly asked for the hydrouretronephrosis. Okay, so that is another important, simple, straightforward that answer. The answer everybody know it is stage 3B. I'm not going to talk about the staging. Yes, hydrouretronephrosis. Where do you encounter? Obviously, you see it in the stage 3. Okay, straightforward question. This requires certain explanation. Yes. See, there's a para 1 living one. She gives a history of secondary infertility with amenorrhea. So the catch here is she is one living issue. That means previously she had normal. Now she's coming with a history of secondary infertility and amenorrhea. That is an important thing that you have to notice here. Progesterone challenge test and estrogen progesterone challenge test is also given. They were negative. That means the hormonal levels is not hampered. But here the Q word or the Q or to clue for this particular answer is, okay, this was the clue for this. Okay, so amenorrhea, secondary infertility, the first thing that has to run in your mind is two conditions. One should be your genital tuberculosis. Another important thing that you have to remember is your Asherman syndrome. Okay, so next, another important thing that you have to remember should be your Asherman's syndrome. So here the answer is tuberculosis. Next, this is also another anticipated question, that is a magnesium sulfate. We have discussed this n number of times, and I always recommend to read this in a very particular tabular format. Okay, this tabular format, this is how I teach. I think whoever has attended my class will know that this is how I teach them for a magnesium sulfate. What is your therapeutic dose? That is a very important thing in all the parameters, like in a milliequivalent, in milligrams, in millimoles, to be remembered. How do you monitor? What are the 4 factors that you monitor? Deep tendon reflexes, especially the paternal and knee reflexes. Urine output you check for, respiratory rate, and the cardiac. Okay. So the toxicity, what is the level at which you find the toxicity and how do you manage accordingly? So for this question, remember the knee jerk is present. That is, of course, that is a normal thing. Visual disturbance, it can be imminent of an eclampsia. So you have to continue a magnesium sulfate. That is not an indication to stop. Another one is respiratory rate of less than 18. Again, it's not an indication to stop. If it's going less than 14, it's said to be having a significant, and where you think of a respiratory depression and respiratory arrest. Picture you can get. Now, so the answer is straightforward here is 60 ml over the last 4 hours. See, this topic, why we keep on stressing about magnesium sulfate and hypertensive disorders is, Williams is the one which has been widely followed. So Williams 26th edition tells you about the hypertension. There's a lot of new changes in hypertensive chapter, as well as in the placenta previa accreta. They have named as, instead of naming them as antepartum hemorrhage, they have renamed as hemorrhagic placental disorders. So there are a lot of changes in these two particular chapters. So that's why we anticipate a lot of questions also from these two chapters. Yes, of course, we had question from magnesium sulfate, and this was simple question compared to the other years. Okay, so this was another topic on magnesium sulfate, which is asked every year, at least one question from magnesium sulfate and hypertensive disorders, which is a drug that is contraindicated in hypertension and pregnancy. That means a hypertensive pregnant patient, or she is a gestational hypertension, chronic, or whatever. So, which drug will you not give during a PPH time or post-delivery? It's a very straightforward question. It is the ergometrin, which is the one which you will not give in a hypertensive. Carboprost will not be given in a asthmatic patients. Okay, that you have to remember. It's a simple question, I think. Coming to this question, is a pregnant woman with no previous cesarean section underwent a cesarean for delivery? I think something I've written there. During a cesarean, there was a PPH and the placenta could not be removed, leading to a hysterectomy. What is the diagnosis? See, the answer is the placenta could not be removed. That means, if abruptio means what? Abruptio is separation of placenta before the delivery. So abruptio is ruled out. Placenta previa is nothing but it's a low-lying placenta. There's nothing that the placenta previa will have always adherence. Another one, they're clearly telling if it is adhered, you have another name. That is placenta accreta. Okay, adherence is accreta, increta, percreta, invasive and penetration. So these are the three layers, types that you have to remember in a placenta accreta syndrome, which is also called PAS syndrome. So the answer here is placenta accreta syndrome. Okay. Next, coming to the next question, rupture uterus. Of course, that is not then this one. That is obviously known. Rupture if you are cesarean, how can it rupture? Is it not? Okay. So this is not the answer. So it's a very simple question again. I think this was an image-based question. So I don't know what kind of image that was displayed. So I didn't add any image here because students should not imagine themselves in such things. So it's, please remember, it is the Q word here is the placenta could not be removed. So that had led to the hysterectomy. That means they could never remove. It is not that they're not tried, that they couldn't remove at all. Finally, since there was a lot of bleeding, they have to go for a hysterectomy. This kind of picture arises in a placenta accreta syndrome. Again, this is not a very anticipated question, but I think most of you will be knowing this answer. This is a G5P4L4. That means she's a gravida 5 with 4 living issues, and all 4 girls are all 4 children are girls, and the patients are curious about the sex, and she comes in. Obvious, this is encountered day and out since I'm practicing fetal medicine. That is what is the scenario. If they have 4 girl child or boy who continues the same gender, they of course ask for the sex of the baby. Okay, so what are they even trying to ask in this question? It's about knowing the sex. This question is about the PCPNDT Act. So according to PCPNDT Act, every patient before entering an ultrasound room, especially when doing an ultrasound, they sign saying that they will not be asking for, they give this one consent for the scan, as well as saying that they will not be asking for any sex of the baby. That is what is the PCPNDT Act all about. And here, you might be knowing, you would have approached this much. The next question is, should the person who does the scan always look for the sex of the baby? See, please remember, we look for the ultrasound, we'll estimate the fetal age, anomalies, but never see for the sex of the fetus. So this is one important thing. Provided if the previous baby had a congenital adrenal hyperplasia. So the previous baby was presented with the ambiguous genitalia. So in this baby, we have to see for the sex of the baby. okay, whether the previous history is repeated again. So that is what is an important thing that you have to remember. So here, please remember the answer is C. So the ultrasound you see for the anomalies, and also you will definitely not routinely for all the patients. So we never see sex of the baby. Even the person who's doing a scan will not see the sex of the baby, provided if the previous child is with some of the like an ambiguous genitalia or suspecting congenital hyperplasia can be seen in the successive pregnancy. So you have to see, in that case, you have to see for the sex of the baby. Okay. Yes. This is what we have discussed already. That is a 15-year-old, the victim of rape, presents at 22 weeks for abortion. What advice will you do? Yes, of course, the NTP can be done till 24 weeks. The answer is B. I'm not going to further discuss about this. Okay. What is this question about? See, this question was also a simple question. A patient with a prolonged second stage, you are applying a vacuum, the point at which a vacuum is applied. So they're talking about the flexion point. So the question is about the flexion point here. So your answer is, it is 3 centimeter anterior to the posterior fontanelle is your answer. You can see the image here. You have the posterior fontanelle and the anterior fontanelle. It is 9 centimeter behind the anterior fontanelle and 3 centimeter anterior to the posterior fontanelle should be your answer. That becomes your flexion point. So that helps the baby to be more flexed and delivery. So here this question was a twin pregnancy where first twin is older than the other on an ultrasound. So this question also I'm not very clear. I got it from here and there. Okay, it's a bits and pieces question. I don't know. The answer here is superfetation. I'm not talking much about it because I'm not very sure about the question. So the answer, if this was your question, the answer is superfetation. There's a gap of older than another. I think it's more than a month or so. They give a answer of superfetation. Okay. Okay. This is another important question. I think it could have this time I could see there was a lot of questions from prolapse. Okay. So that is again. Alarm, this one you added in your high yielding topics, prolapse, because prolapse we used to read only surgeries. Yes, if you know the surgery, this was an easy question again. A 30-year-old presents with a cervical elongation. Her family is complete. What is the preferred surgery? Most of you will be knowing the answer, and the answer is for the grill. Okay. There's no much this one, and I think there was a one more option, Latsko operation. Latsko is not done here. Latsko is for in case of a fistula. Okay, so Latsko is one more option. I think instead of ward Mayo, I think it's Latsko. Okay. A young woman presents with prolapse. A mesh is placed. So where is this prolapse? So it is, please remember, it is the sacral promontory. All this is our, I don't think it's there will be any confusion in this. These are simple questions. So you could see already we got 1, 2 questions here, is it not? And there was a third question on the way from prolapse. So this will come under your high yielding topics. A patient experience softening of the cervix. This sign is called the Google sign. Again, this I'm not going to explain. It's a very simple question. If you would have studied, because we will be concentrating on higher topics, is it not? This was a basic question, simpler question. When you start with your obstetrics, you would have started with this question, is it not? So the answer is Google sign. Others are also the other subjective signs that we encounter in a first trimester pregnancy, first trimesters. Okay. Okay. This question was a previous to LSCS. Okay. It is not normal delivery. It's a previous to LSCS with a primary HSV. See, if she is even a primey and she is having a herpes simplex virus, viral infection, again you go for a cesarean only. So she is previous to LSCS, herpes simplex virus, you go for a cesarean. There is no further discussion on this. Okay. This question, I think they keep on asking you the same question, but in a different forms. Okay. So this question was, So of course, so easier way, it was a primary amenorrhea with the normal secondary sexual characteristics. Uterus and ovaries are present. What is the likely diagnosis? I don't know what picture they had given, but this picture is the one I could found it as. So you could see that the imperforate hymen. That's what they try to show here. Okay, imperforate hymen is just the obstruction. Okay, so where you give a cruciate incision and this gets clear. So that means she is having a primary amenorrhea only because of that obstruction. Coming to her secondary sexual characteristics are normal and uterus and ovaries are present. So what will be her karyotype? No doubt the answer will be normal karyotype 46XX. Okay, this is whatever they're showing is an imperforate hymen. Implantation of embryo takes place how many days after fertilization? I was very happy seeing this question because always they keep on asking a very high funda questions. I could see certain simpler version questions, basic questions which was previously asked also has come this time. Yes, one such question is this. The answer is 5. A patient presents at 10 weeks. She asks for medical management method of abortion. What will be your advice for? Here we have a table. Okay, this table has been repeated. I think past 2 NEET exams they have continuously asked these questions in a different forms. That's what I'm saying. You could have gone and seen your next last 2 years of papers also. You could see the same question in a different format. Okay, what are the other methods? What are the only methods that you see in first trimester? So this is how they keep on asking questions. Okay, the answer is very much simple. It's MIPI and MESO that has been, it's a medical method. All other things are nothing but the medical, surgical management. It comes under that. That is hyperosmolar saline. All these are in the second trimester they go. Okay. LSCS for breech was done intraoperatively. This was seen. See, there I forgot to add a picture of an ECB. So the picture was on ECB. Sorry, I don't know. Not this. There's another question. Okay. Intraoperatively, they could see 2 cervix were also identified. What is your diagnosis? So what is your diagnosis? See, bicornuate, unicornuate, arcuate, all these are at the level of the fundus. The thing that extends even up to the cervix is the uterine diadelphys is the answer. It's a clear cut. See, when I say arcuate, you have heart-shaped heart at the fundus. Bicornuate, you have a shape. Okay, here you have a proper heart shape. Is it not like this kind of thing? Okay, unicornuate is you have a unicornuate uterus. Is it not? Diadelphys is extending up to the level of the cervix. So that's what it will present as 2. So the answer is diadelphys is a simple thing. Okay. The uterus also. Here you could see the uterus also will be like this. Okay, this is uterine diadelphys. Coming to the next question, a patient comes after 6 months of vaginal delivery with an episiotomy repair with a pain at the site of episiotomy which increases with or during her periods. So please remember, the answer is very simple. It is definitely not suture. If it is suture, she should have pain all the time. Is it not? Only during pain, it will not be there. And it should not increase only during the periods. Hematoma, it's the one thing which can be long time. It cannot be in a, it cannot be in a chronic state. Okay. And melanoma, definitely not. The answer is endometriosis. If you would have got confused, you would have got confused between A, B, C. Definitely. Nobody would have chosen melanoma. Suture, you should have a continuous pain all the time. There's no specification that it will happen in a particular, like you only increases during periods. Only during periods it increases. That means only the endometriotic tissue reacts to that during cycles, is it not? So that is your answer. Of course, the answer should be your endometriosis. Coming to the next question, after ovulation. See, actually, this question got to complete it. So they've asked about, the answer was secondary oocyte arrest in the meiosis stage 2. That was the answer. So after ovulation, the egg is in the secondary oocyte arrested in the meiosis 2. Okay, this is another question. Okay, all these are your paper 2, I think. So I've added in the end. That's why I couldn't format it. So what do you think is the answer? Most common site of tubal ligation, you know, where is it? Tubal ligation is the isthmus. Why do you do it in the isthmus? So isthmus is your answer. So ampullum, I'm not doing. So what will be your answer? Is your isthmus. So the answer is B, which is becomes the narrowest area. It's easy for ligation. Coming to the next question, a 26-year-old lady, she has conceived with IUCD. What will you do? Leave IUCD in situ, you do an MTP, remove IUCD gently. This has been discussed a number of times of an IUCD missing property, thread of a property. Another one is pregnancy with an IUCD. This is always discussed topic. These two topics has to be remembered all the time and it has to be continuously revised. See, the simple thing is here is IUCD is not an abortifacient, first thing, okay? Intrauterine contraceptive device is not going to be abortifacient. It's not going to terminate the pregnancy. Yes, there is a risk of infection, rupture of membrane, all this and advancing, okay? All these things, there are certain things that will be postulated. But as soon as they confirm pregnancy, next you have to always, the question also says that she wants to continue pregnancy. So she wants to continue pregnancy. We always prefer to remove it. You look for the location. So prefer to remove. That should be your first step. Next is you see for the location, whether it's a fundal area or it's below. Just with a forceps you can gently remove. If it's at the fundal area, okay, then you have to think, try to leave it in situ. If it's at the very fundal area, you can't reach unnecessarily. You're not going to disturb the pregnancy. So for that IUCD, you're not going to reach up to the fundus. Is it not? So first thing is whether the patient wants to continue pregnancy or not. If the question clearly states that she wants to continue pregnancy, then the next step, obviously, the answer is to remove the IUCD gently rather than leaving it in situ. If it's not, if it's at the fundal area, if the same question says if it's in the fundal area, the answer would have been leave it in situ. Termination, definitely we don't advise. Next, a 45-year-old woman with a history of cervical erosion and spotting. She have erosion and spotting since 2 months. What is the next step? Of course, the answer is C. PAP and all is become a older method. Now they do liquid-based cytology with HPV, which has a higher this one, and they also, I think the cervical biopsy was also added with this. I'm not very sure. I got from some students, cervical biopsy was also there, but LBC with HPV. So that becomes your answer. Very next question is drugs contraindicated in asthma. That's I told you it is the carboplast. No discussion on this. Nugent's score, yes. See, bacterial vaginosis, as whenever I've taken class, I have told you, Nugent's score, here it is in bacterial vaginosis. What are the other scoring systems? License scoring system, license, L-Y-S-O-N. License, where you see for the number of the lactobacilli that is present. Okay, so license scoring, Nugent scoring, Ansell's criteria is one that clinically we see for the bacterial vaginosis. The answer here is the bacterial vaginosis. Now coming to few this one, phase to pubis delivery. This also has been discussed a number of times. See, though we should have not read pelvis also, I always tell them if you can't read in the end moment, always revise this before going to exam. Must know, that's what I give them, must know, or to say it is fast express to read. Okay, in our revision classes also we had this, where android pelvis we produce a persistent occipito-posterior position, and in the anthropoid pelvis, remember, it favors the phase to pubis delivery. So it is the answer was the anthropoid pelvis. This was the anthropoid pelvis that you can see anterior posterior, AP, anterior posterior is more than that of the transverse. So anthropoid. Okay, so anthropoid is AP. I always remember anterior posterior diameter more than the transverse diameter, and it favors the phase to pubis delivery, more common, and favors direct occipito-posterior. But if your question says what is a persistent occipito-posterior position, it's favored by the android pelvis. Okay, again this was a simpler question. Now coming to the image-based questions, they've asked a lot of questions on breech. Okay, breech, of course, it's a very important topic, and as anticipated, most of the image-based questions were from breach presentation. I think there was another after coming head delivery, the manuals. What are the other manuals? I think one thing. This is a very simple question. There's no further discussion on it. It's a 5 to 4 steps. That is what we use for the after coming head. And now there were a lot of questions they keep on asking on this vaginal lacerations as well as this oasis. Okay, so this answer is she had a vaginal delivery, and following which she had a tear that is extending. It's not here, it's tear. Okay, sorry, it's T. Extending to the rectum. The answer is 4th degree. That's a simple question that I've asked. Of all that grading, this is a 4th degree. Identify the ultrasound image. See, either you would have got this or this. I'm not very sure, but the answer is frog eye appearance. You can see there is no calvarium. Okay, so that's why it gives this face as more prominent, giving a frog eye appearance, frog face appearance. And this is the anencephaly, where you cannot see the baby's head. It should have been like this, which is absent, and this whatever you're seeing is the brain tissue. So this is an anencephaly. Another image-based question. This classification is shown for which? It's a very simple, very traditionally, very old classification. If you would have seen this, you would have understood. They have taken as the genital hiatus, perineal body, transvaginal length. All these are the landmarks that have kept an anterior wall, posterior wall, and they've graded. I have to talk about this is the POP-Q grading system for the pelvic organ prolapse. It's a POP-Q, very old method, traditional method, which still followed. Okay. So, prolapse again. There was a lot of questions. Yes, now the prolapse. See, I didn't get a proper image to explain to you, but as most of them told, it was a grade 3 prolapse with cystocele. So I didn't get an image. This is what I could get it. I couldn't get the actual image. So the answer is grade 3 prolapse with cystocele as far as whatever the students have told me. So this image was a vaginal smear that is directly pointing towards trichomonas. Definitely not bacteriovaginosis, candidiasis, or HPV. So the answer here is trichomonas. What is the karyotype of this girl presenting with primary amenorrhea? That it's a very simple. You could see here, this is X and there's nothing in Y. Can you see this? So it is X. So it is the Turners. Okay, Turners. So simple, it's Turner. There were a lot of other image-based questions like in hydrosalpinx, fibroid, and chocolate ovarian cyst. Similarly with, that's what I told you. Morrissey similarly with Samonier manual is for the delivery of the after coming head in a breech. And ovarian cyst, there was one question. Okay. Another one, they told me there was a salpingogram of an showing there of a hydrosalpinx. Another one is a fibroid. So these both, see, fibroid I'm particularly not added because I'm not very sure it is a fibroid with adenomyosis. So I should not make you think it's something to do with fibroid. Still, I would say this is a question mark for me. Okay, I don't know. They say it's a fibroid. Most of them told me it's a fibroid. It's a fibroid. Most of them have decided if it's a fibroid, then I'm okay. So definitely you had a question on chocolate ovarian cyst, the image-based questions, and you had this on the assembly with. I don't know if it was this manual only. I do something HSU. I think we have come to the end of your recall. I could have missed a lot of questions. See, this is what I could collect from the students. Nothing that is, if I've not added anything, please add on to your chat boxes. Okay. Or you can contact us for if you have any other questions or queries on this. And don't lose hopes. Okay. Whatever may be the results. Okay. This is for all the upcoming students also who are going to plan for your next year, who are this already preparing for next year. I think this will be a good way to see what are the questions, what is the pattern. So that will help you or plan your exam for your next. Okay. So your next whatever NEET or whatever is coming up, this exam you can plan accordingly with this week also. Okay. Thank you so much.